Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on Ambien, one of the most popular sedative hypnotic agents in psychopharmacology. It might be a little more expensive than some of the others, but it is available in a generic formulation and it is extremely popular. Ambien, as most of you probably know, is a sleeping pill. It is a non-benzodiazepine hypnotic agent that has been shown to increase the total time of sleep and to reduce the amount of nighttime awakenings. And Ambien CR, controlled release Ambien, is even more effective at helping a person to stay asleep, especially in the long term. I just did a two-part series on benzodiazepines where I talk in detail about the mechanism of action of that class of medications. Ambien is a non-benzodiazepine, but like benzodiazepines, it too is a GABA positive allosteric modulator. GABA is gamma-aminobutyric acid, which is the main inhibitory neurotransmitter in the central nervous system. And the way positive allosteric modulators work is Ambien will bind to, in this case, the benzodiazepine site, and that causes the receptor, which is a protein, to change shape. And because of that change in shape, it's a conformational change, it increases the likelihood that GABA, endogenous GABA, that's just floating around your central nervous system because your body's making it, increases the affinity of the receptor for GABA. So it increases the likelihood that GABA will then attach to the receptor, stimulate the receptor, and then inhibit the neuron that receptor is on. So the neuron won't fire as frequently. And that leads to all of the effects, the sedation and the muscle relaxant and the anticonvulsant and the anxiolytic, anxiety-reducing effects of these types of medications that increase GABA. The important thing there is that because benzodiazepines and Ambien, medications like Ambien, don't stimulate the receptor directly, they're not agonists, they're much safer in overdose. Because even if you take an intentional overdose, take the whole bottle of Ambien and you've saturated receptors with Ambien, all that's going to do is make those receptors especially sensitive to GABA. But there's only so much endogenous GABA around, and so you would just have to take a massive overdose, bottles and bottles, in order to have enough GABA on enough receptors to make you stop breathing, to kill you. Unlike, for example, barbiturates. Barbiturates, medications like phenobarbital, they are also positive allosteric modulators, but they actually stimulate the receptor as well. They mimic GABA. So if you take enough, then you will have receptors saturated throughout the CNS that are actually shutting those neurons down, including neurons in the medulla oblongata, part of the brainstem that contains the respiratory center. So Ambien is a non-benzodiazepine GABA positive allosteric modulator. It is FDA approved for the short-term treatment of insomnia. And by short-term, we usually mean 7 to 10 days. Importantly, the controlled release Ambien indication is not restricted to short-term use. And so if you want to prescribe Ambien more chronically for insomnia and you want to stay on label, then consider the controlled release preparation. And this also makes sense because Ambien is very short acting. And once you develop tolerance to Ambien, there's a tendency for it not to last throughout the night. People tend to wake up on Ambien once they've been taking it for a while. And that's why you see a lot of complex sleep behavior that I'll describe in a minute. But people get up, they eat, they make phone calls, they even will get in the car and drive to the corner store to buy Oreos and not remember it sometimes, or barely remember it. So they have amnesia and they have all these side effects. And it's not because Ambien is any worse. Any benzodiazepine would have the same effects, or for that matter, barbiturates. But the problem with Ambien is that you're supposed to be asleep and it's just not keeping you asleep. Ambien CR, controlled release, is much better at lasting through the night, And even after you've been taking it for a long time, it tends to keep you asleep throughout the night. Maybe that's why the FDA didn't say, but only for a few days. So it's worth considering. The risk of dependency is thought to increase with the dose and the duration of treatment. So this is a medication that is habit-forming. It can be abused. It's a Schedule IV drug. The DEA has 5 schedules of controlled substances. The higher the number, the less controlled. So these are 4 out of 5. There's a lot of medications that the DEA is more worried about when it comes to abuse and physical dependence and withdrawal. But they do cause physical dependence and withdrawal, and you can have a seizure in withdrawal, and withdrawal can be deadly. So just because they're Schedule IV doesn't mean that they're not dangerous drugs. They're classified as dangerous drugs by the DEA. We also have approval as needed for the treatment of insomnia when a middle of the night awakening occurs and is followed by difficulty returning to sleep, so middle insomnia, and there are at least 4 hours of bedtime remaining. That's the sublingual intermezzo.
When you wake up in the middle of the night, it can be frustrating. It's hard to turn off and go back to sleep. Intermezzo is the first and only prescription sleep aid approved for use as needed in the middle of the night when you can't get back to sleep. It's an effective sleep medicine you don't take before bedtime. Take it in bed only when you need it and have at least 4 hours left for sleep.
So it works quickly because you absorb it through the mucosa. Food does affect the absorption of Ambien. You really want to be on an empty stomach when you take Ambien the normal way. But you absorb Intermezzo faster and the doses are lower, and so it can get you back to sleep, and it's recommended if you have at least 4 hours to go. The mechanism of action, as I've stated, it binds to the GABA-A receptor as benzodiazepines do, but Ambien, zolpidem, binds selectively to a subtype of that receptor, the alpha-1 isoform. And without getting into chemistry, the significance of that is that Ambien is more selective, and we think that that might target the sedative-hypnotic effects of this medication more than some of the other inhibitory GABA effects, like muscle relaxation. And alpha-1 selective non-benzodiazepine hypnotics like Ambien may cause less tolerance or dependence than benzodiazepines, so they may also be safer. Generally, Ambien is considered less addictive than Xanax, for example. Ambien has a short elimination half-life, approximately 2.5 hours. It's prescribed at 10 milligrams a day at bedtime for 7 to 10 days. That's the immediate release preparation. 5 milligrams are recommended for women because the clearance of zolpidem is slightly slower in women than in men, and in some patients, zolpidem blood levels are high enough the following morning to impair activities that require alertness, including driving. This was a finding that was after the medication had been approved and after the original package insert, and that prompted the Food and Drug Administration to issue revised dosing requirements. So it's not just because men are bigger than women generally and have a larger volume of distribution, it's actually because they appear to be more efficient at clearing the medication as well. But the FDA has actually suggested that we consider 5 milligrams in men as well. It's officially approved at 5 milligrams for women. So the 10 milligram is not approved in women, is the point I'm making. But of course, you titrate the medication, and it really just depends on how long a person's been taking it. You might very well eventually increase a woman from 5 to 10 milligrams after she's been taking it for a while, or from the 6.25 to the 12.5 milligrams if you're using Ambien controlled release. This is interesting, this idea of Ambien's effects carrying over to the next day. I took Ambien for a period of time, and it worked very well for sleep, and I would wake up and not have trouble waking up. I wasn't groggy. The next morning, I felt refreshed and ready to go to work. and had no problems there. But I was taking 10 milligrams, which, I'm a pretty small guy. So even though it's FDA approved for me because I'm male, still, it was a hefty dose. And it didn't happen right at first, but it happened with cumulative dosing. As I continued to use it, I started having double vision, diplopia, while driving. And it was the following morning, and it would last usually just for an hour or two. And maybe if I was tired, it would be more significant. I'd have this double vision while driving to work. I didn't know what it was. I didn't know it was the Ambien. But I wasn't even sleepy or groggy. And yet it was causing diplopia because it causes muscle relaxation. Just to be on the safe side, the FDA does recommend healthcare professionals consider prescribing lower doses to everybody. The controlled release is 12.5 milligrams and 6.25 milligrams. Intermezzo is available as a sublingual tablet, and that comes in very low doses starting at 1.75 milligrams for women and 3.5 milligrams for men. Again, if you have at least 4 hours of bedtime remaining, with 5 and 10 milligram doses also available. And so you titrate to the tolerance. And so at some point, you could actually be giving somebody 10 more milligrams of Ambien sublingually in the middle of the night to get them back to sleep. It's not recommended to take more than 1 dose of Intermezzo a night. You're only supposed to do it once. Although if you use the CR preparation, and particularly the higher dosage, that's what I would do before resorting to having the Intermezzo. The instructions are to allow the medication to dissolve completely in your saliva before you swallow it. Food does interfere with the absorption. If it doesn't dissolve completely and the pill fragments reach your stomach, they're just going to sit there on top of any food that you might have, and then they have to get into the duodenum before they can be absorbed, and the whole point is to get back to sleep quickly. Ambien is notorious for increased wakefulness during the latter part of the night, i.e. wearing off with long-term use. It's probably why the FDA has only approved it for short-term, because people develop tolerance to it and then it's not working to keep you asleep. Adverse effects include daytime sedation. That's not common. It's short-acting, and so we usually see the opposite problem eventually. Terminal insomnia. Waking up and you're awake. It's 3 o'clock in the morning and you're not getting back to sleep until morning, until you have to get up until the following night. So being sleepy the next day is not real common with Ambien. And the name, it's got one of the best names, Ambien, A-M-B-N, right? Good in the morning, you're good to go. That's pretty true of Ambien. Ambien's a good medication as far as sleep aids go. As far as non-benzodiazepine GABA positive allosteric modulators go, it's a pretty good one. Dizziness, ataxia, which is a gait disturbance. This is, of course, if you get up, get out of bed. And dose-dependent amnesia, so the more you take, the more likely you are to have anterograde amnesia, where you don't remember what you did, these complex sleep behaviors. That's really a misnomer. You're not asleep. Complex sleep behaviors are defined as behaviors that occur in a sleep-like state, when you're not, quote-unquote, fully awake, but you are awake. Sleepwalking is included in that, so you're not necessarily responding appropriately to people who might be trying to get your attention. That's more of I think sleepwalking, it's a parasomnia, and so you really truly are in a twilight state, maybe stage 1 sleep even, whereas complex sleep behavior like eating or making phone calls or even driving to the store after you've taken your Ambien, that's a blackout. You're awake and you might be very uncoordinated, you might have ataxia, and if somebody talked to you, dysarthria, slurred speech, because you're supposed to be in bed sleeping. But the reason that we call it sleep behavior is because, you did it in your sleep. Well, no, you did it after you went to sleep. Then you woke up and you got up, and I'm talking here about, not about sleepwalking, but about taking Ambien and then doing stuff and talking to people and having sex. These are things that, and whether you remember it or not, you're intoxicated, you're under the influence, and it can be dangerous, obviously. In fact, a history of complex sleep behaviors after taking a sleep medication is considered a contraindication to Ambien because it's so common. But again, if you drive to the corner store, you're awake. You can't drive a car while you're asleep. Okay, when you fall asleep behind the wheel, you crash. Semantics maybe, but it's important to understand really what's going on. Sleep driving and other complex behaviors such as eating and preparing food and making phone calls have been reported. In some cases, the behaviors have resulted in serious injury or death, and that prompted the FDA to require a black box warning about these behaviors with Ambien. To avoid problems with memory, only take zolpidem or zolpidem CR if you're planning to have a full night's sleep. And Intermezzo only requires half the night. And that's pretty much it for Ambien. Thank you for listening.